Good afternoon.
Good afternoon.
Good afternoon, hey.
I would like to welcome you all here to the Oregon Hypnotherapy Association. This is our first real live face-to-face get together for I think several centuries.
Yes,
100
it
years.
seems like.
And to begin, before we begin our show, we're all here to do one thing, is learn how to direct people's attention, right? How to change their minds. And it's a kind of an illusion, you know, we're moving people from one side of their mind where they're like, here's they pay the bills, or left side thing, and then we have to move them to the creative side, to the imaginative side, reframe their minds and things. And that's exactly what magicians do, right?
And would you be willing to remove your hat? It's casting a shadow.
Well, that's
on
sure.
your face.
Can I do this? Is that better?
I think the audience at home can see your face.
Yeah, well, okay.
Just for that.
To that end, I brought 3 links of Brody grab, hold that, just tug on, just to make sure there's no, it's a real piece of rope, okay? So this is a large piece of rope. Okay, and here we have a small piece of rope. Small piece of rope. We have, you know, a medium size piece of rope. I one time, and I shouldn't say this, but one time I did a show and I said, we have, you know, like we have a mama rope, we had a baby rope, and we had mama's boyfriend rope. That didn't go over very well. Anyway, so the illusion is what? We have 3 ropes of different lengths, right? But everything vibrates, right? We have, so as we vibrate these ropes, at the atomic level, we can see that actually we have 3 ropes of the same length. 1, 2, and 3. This is where you go.
Wow.
So we have what appears to be an illusion, 2 pieces of rope, but in fact, it's actually just 1 piece of rope.
Recording in progress.
You have a pretty good imagination. Could you do something like finger set there and cut the rope down lower where my hand is?
Snip.
Okay. And so we have, once again, we're back to piece of rope, back to 1 piece of rope. Okay. Here, she's standing on the side, see if I'm cheating. Of course, and I am. So if you take these ends, pull them off, and you call a loop. There we go. Put it back on. And one last time. You do this another time. So we have the 3 ropes, and then if we really, really go back, you find we have little rope, mama rope, and the big rope. And now I'd like to introduce Joni to our president to give some introductory remarks.
That'd be great.
Very cool. I didn't know I said that.
Yeah, we got it. Okay, so there's a few things that we still need to work out. No, with the Zoom. Did you get it? No. We'll let Scott do this.
It's not this.
I am so excited that we are all here. We've got people here in person. We've got people here by Zoom. We have been trying to do this for years. I think this is one of the best things that came out of 2020, is that we're finally getting to do this hybrid kind of a thing, so we can get people like Michelle and our speaker David from across the country to visit with us today. And that's just fabulous. Thank you so much for being here. a few little housekeeping things. One is if you're on Zoom, please mute yourself unless you're actually talking. And for everybody that's here, if you don't know already, bathrooms are down the hall to the right. And in the back, I've got a place for water bottles after you're done with your water, and another place for the plates and utensils. Just put it all in there. I will take care of taking care of that. All right, so we don't use the big garbage can. We got it. Scott saves the day one more time. I have to give a really huge thanks to Scott for managing to figure out how to make this work. We've been here a couple of times already in this room to try and get this to work. And Scott, you are amazing. Scott. So thank you to everybody that has helped out. Like I say, we've been here a few times. We're getting it all worked out. And I would now like to present Jean. She's going to introduce our speaker for us.
Thank you, Joni, and welcome everybody here and virtually. Glad to have you here. It's my pleasure to introduce David Flemming, and I have known David since 1984. And little did I know that when he first taught me self-hypnosis that I would be a hypnotist years later. So one of the things, David, that I really appreciate about you that I want to share with people is that you have a heart of compassion. You know, being British and a doctor and all that, I can remember how, you know, people would, you know, there's that whole British doctor thing, right? Oh my goodness, I love your accent, right? So you are one of the most down-to-earth, compassionate, wise, and aware people that I know. And everything comes from your heart, my experience of you, that the work that you've done with patients, how you interact with people, you understand about people. And you love them and you help them any way that you can. And you've been doing that for a long time. You are the microphone, the cameras, by the way. They're right there? Okay. So you've been doing that for a long time. And I want to thank you. I want to thank you. And I also want to acknowledge the team of people that have worked with you, that joined you on your path to figure out effective treatment for CRPS. I want to acknowledge Joy Flemming, your wife, and Michael Gaynor, and Carol Lowe for doing that, all of you for doing that work, and for kind of opening the door to say, where can we empower people's lives and help them to live more gracefully and comfortably by combining our resources and our viewpoints and working together cooperatively. So thank you very much. Welcome, David. Welcome everybody from Zoom. Welcome everybody here.
Well, thank you very much for the invitation to start with. I wanted to share this information, and this is a really good start. I have spoken to various, excuse me, coughing at you. I have spoken to various hypnotic societies in the past, and this is the beginning of the new bit. The idea is to share this information now widely, and not only just with people who understand hypnosis, but standard medicine and standard rehab stuff as well. Let's see if I can share screen. Oh, the host has a host. Who's the host? Can you enable me to share my screen?
Yes.
These co-hosts, you should be able to share.
How's that?
Not yet. Hold on.
Okay. I think you have to set me up as host. That means I can terminate the meeting, I can turn everybody off.
So I think you should have, so you are also a co-host, so you should be.
Okay, here we go then. Yes, we got it. And here we are.
There we go.
And this is slideshow. Look, here we go. So what we did in our office in Chicago, we combined standard medicine, hypnosis, and psychology. And I got into the management of CRPS quite a long time before that. And we got involved with some other physical ailments as well, but we didn't collect a lot of information on those. So I'm not 100% sure that what we learned from CRPS was actually really applies to these other things. But we're talking about illnesses, physical illnesses. Illnesses all have three major components. One is the symptoms that we experience. One of the physical signs you can find upon examination, like listening to the chest, for example, or measuring blood pressure. And the other is the response to doing tests, such as body scans or advanced blood work or anything of that kind. So if we get repeated patterns of all these different things, they lead to the name for the diagnosis that the person or even ourselves is experiencing. And as my first example, appendicitis is clearly a very logical physical disease. You get symptoms, you get pain and tenderness in the belly, you get fever often, you get bowel problems, you get elevated white cell counts usually, and the scans will often show that the appendix is swollen, and it may show other things too, like lymph nodes, for example. But the thing about appendicitis is that the diagnosis is logical, the treatment options and the outcomes are clear. It is almost mechanical. It's like, hey, you know that you have a flat tire in your car, and what you do, you have to stop the car, put the jack underneath, raise the car up, and you have to change the wheel, and then you're fine. And appendix is that logical. Now, the next example I've got is of another physical disease. Oh dear, beg your pardon. I thought I'd turned that off. Anyway, the name complex regional pain syndrome tells us that it's not quite as straightforward as appendix. First of all, the name complex suggests that the illness is not clearly understood. There's a lot going on there with CRPS that is not really clear. The next thing is, this is a logical bit, it affects people in regions. So it affects arms or legs or one side or the other side, and there's a recognizable pattern that a patient may feel that indicates where the symptoms are. The main symptom is pain, but there are other symptoms too, like muscle spasm and all kinds of things. And the term syndrome, that indicates a recognizable pattern of all those symptoms and signs and physical tests that might indicate what the diagnosis is. And because it's so complex, the treatment options and the outcome are not always clear. But the thing is, there are clear physical signs. Here, for example, there's a lady who's had this CRPS for quite a long time. Look at her foot. It's sort of swollen. If you could examine it more closely, you'd find that the skin is thin. If you do scans of her bones, you'd find that they are weak, they are decalcified. And the same applies to this hand on the right. And actually it's a left hand, but it's right side picture. And here's somebody who has severe vascular issues, which are to do with vascular changes that happen with CRPS. But the fact that there are such severe physical signs confirms for us all that this is a physical disease. And each of these present with symptoms, signs, and test responses, and they establish what a disease, what the name of the disease. And there's a big difference in that CRPS, the severity frequently varies with mood and stress and anxiety and other emotional issues. And this suggests that there is a link between this physical disease and psychological issues. It doesn't just suggest it in most patients, but not all. It confirms it. Now, if you look at the literature that's online, either online or in the medical journals, medical organizations tend to downplay this. And that might be because it's not something that they are in a position to really examine. I mean, how many medical organizations have a psychologist deeply involved in it? So you can understand why medical organizations don't really emphasize this link. The literature of hypnosis and psychology does show encouraging outcome when CRPS is addressed, when standard medicine and psychological interventions are combined. And so I asked the question, is it time to investigate this? And of course, the outcome is, the answer is yes. And the reason it's yes is because there are thousands and thousands of people who have illnesses that might respond to this form of management. And this information needs to get out. Now, my introduction to hypnosis happened here at this pub in England. This was just up the street from the medical school, and my good chum, he was my chum. Dick Teo and I were in this talking about this and that. Oh, we had a beer as well. And he was saying, oh, I just did a little course on hypnosis. Would you like to tell me about it? And I said, oh, I'd love it. So we started doing a little hypnotic sort of education. And we did some hypnosis too. But I think my mind was so attuned to observing what was going on that I couldn't let the system get into my brain. And I ended up feeling that hypnosis was a load of bunk. And I didn't think it had any merit whatsoever. But the basis information that you find in this talk is really to do with learning about hypnosis further. And round about 1973, I came over to USA from England, and I worked at the hospital of the University of Pennsylvania, and they had a hypnosis course. So I thought, oh, I'm going to enroll in this hypnosis course because I just want to confirm for myself that hypnosis is really bunk. But to my shock and astonishment, I found that it is not bunk in any way. It is extremely powerful. And I can remember clearly the event that happened just to switch my mind on this way. We were doing a hypnosis session and we were talking about arm movement in trance. And I noticed that my arm was moving without voluntary direction at all. And I thought, oh, OMG, something has happened here. This is awful. Now, my involvement with CRPS really came because I'm an anesthesiologist. Anesthesiologists do two things particularly well. One is they manage the airways, because whenever we put people off to sleep, they cannot breathe anymore. Usually that's the case. And so unless we can manage it, a patient dies. So we got to be 100% guaranteed to be able to manage airways. The other thing we get to do is nerve blocks. And at the time, it was fairly clear that CRPS was strongly involved with function of the autonomic nervous system, in particular the sympathetic nerves. And my job was to put local anesthetic on those nerves. And hey, the more you do, the more skillful you get. And that was great. But hardly anybody got any long-term help. In fact, I think nobody in my group got any long-term help. But I read an article on the use of hypnosis in CRPS, and it looked optimistic. So I tried it. And I was totally astonished that so many people were able to drop both symptoms and physical signs of the disease using hypnosis. That was great. And the thing that was really surprising for me was that of the patients who were able to drop symptoms and signs, about half of them were not really interested in coming back for more. I'm going to talk more about this later, but later we got involved with psychology and we got involved in massage therapy too. We'll be speaking more about that. And we did observation of outcomes and we shared as best we could with other disciplines who were interested in management of CRPS. Of course, I was really surprised that hardly anybody was interested. And I just wonder if it's because, you know, hypnosis has a funny name, doesn't it? It's called animal magnetism. But twigs will do the same. So you think, maybe the world thinks that hypnosis is a little strange. You know, and also hypnosis is used in the entertainment industry. And that makes it look a little bit strange from the medical standpoint too. Maybe these are things that we have to address. But what was really interesting is that 85% patients we saw with CRPS scored very high on the hypnotizability scale, which I think is fabulous, most interesting. Does that mean that people who are high on the scale are more vulnerable to getting this illness? I don't know the answer to that, but it would really be something that would be good to study in the future. And again, about half of these were not interested in continuing to explore what we were doing, which is most interesting. And then I got really involved because I read an article, and it was by Dr. Michael Gaynor, and he was a psychologist who'd been using hypnosis to treat dissociative disorders, and we'll be talking more about what they are later in this talk. And 3 of his patients had CRPS, and all 3 of them, the symptoms dissolved when the dissociation got under control. Anyway, he was coming into Chicago the very following weekend to a conference, and so we decided we would meet. We met in a very nice restaurant in Chicago, and we talked a lot about CRPS, talked a lot about hypnosis, and we discovered that we both liked the same kind of beer. And on those grounds, we decided to form a clinic, which we did. And we were joined by Dr. Carol Lowe, who I think maybe somebody you know, because I think she is or was a member of this society, which is great. And we all had our roles. The medical role was to confirm that the diagnosis CRPS was correct. And it wasn't always. We needed to check that whatever the patients were receiving was safe. And of course, one of the things we were concerned about was heavy opiates, because heavy opiates will reduce the pain threshold, and it will make it much harder to manage. My job was also to prescribe and give medical management, which was known to be safe and effective. And that would include things like local anesthetic nerve blocks, muscle relaxants, sometimes to give analgesics too. We were really interested in giving massage therapy, particularly when the pain had been resolved with using some other method like hypnosis or with local anesthetic blocks or muscle relaxants or something of that kind. And the reason is because massage therapy helps muscles to relax. And in CRPS, muscle spasm can be a really severe exaggerator for symptoms and signs. And of course, the most important thing was to work in close collaboration with all the other systems that we had in place, in particular with psychology. In fact, for many years, we worked, the psychologist and the medical services worked together in the same room, and they communicated with the patient in the same way. And I think that's how I got to learn a lot about hypnosis in this illness, dissociative disorders and ego state therapy, all that kind of stuff. But I have to emphasize that management of dissociative disorders is not my primary training. So I didn't really get directly involved with that. You know, I could use hypnosis sometimes to help people reduce symptoms. But if you're doing this work and your patient gets in contact with a traumatically related ego state, that can be very harmful. So the person who's really needing to do that with somebody who's really experienced in the management of that. The psychologist's role was to test hypnotizability, to induce hypnosis, to explore the capacity to reduce both symptoms and signs, and most importantly, to explore the meanings of those symptoms and signs. And that was absolutely key, because when they emerged, the psychologists needed to explore them and manage them deeply, helping the whole thing to resolve. And again, I will emphasize that my own training in this was not really adequate to involve me to get directly involved. We perceived that there was certainly risk if dissociation and the traumatic ego state was involved. In this illness, which at the time, and I think it still is considered, I think maybe incurable isn't the right word, but the long-term remission rate is very small. We saw long-term remission in 60% of them, which I think is really impressive. Gee whiz. Now, we used an evaluation scale for the severity. And it's important, if you're doing studies of this kind, you need to be as objective as you can about measuring what the illness is really doing. I'm going to show you the scale we used on the next slide. But I have to tell you, I'm not really sure that it's really important to go into this slide in detail. And the reason is because it's not so much the content as giving you the message that you need to go into this in extreme detail. Now, in those who were helped, symptoms and signs were reduced to minimal, to levels permitting normal function, or even down to nothing. And resolution of involved psychological issues and techniques learned during treatment led to self-management and persistent remission, and this lasted at least until the clinic eventually closed. Here is our score sheet. We were looking at the distribution of where the symptoms were. We were looking at pain levels and sensitivity to touch, what cold felt like, how it affected your mood in terms of depression and anxiety, in terms of function, in terms of atrophy of skin, nails, or hair, and atrophy of muscles too. We don't need to go into that in extreme detail. But I do want to go into much more detail when it comes to the progress algorithm that we saw. And if you looked at all the patients we saw, we tested for hypnotizability. 85% were at the really high end, and 15% were at the extremely low end. There's hardly anybody was average, if anybody at all. And in this group who had low hypnotic ability, we were not really able to help them any more than they were already helped by their standard management. Now, of the 85% who had a high capacity, we found that there was a stack of them who used and learned hypnosis very quickly, and they were able to deal with symptoms and signs. The psychologist, Mike, did not get any notice of any psychological issues, and there were no physical issues that I could determine either that would act as maintaining factors. And this group got to be and went into remission for a long time, maybe permanent. Now, the middle group was a group of patients. They were able to use hypnosis, but they couldn't do it for very long. And I examined and I looked at charts and all that stuff, and I determined that a lot of these had some other physical source of pain, like nerve entrapment, neuromas, mononeuropathy, joint pathology. Nicotine use always blocked success. And if we were able to seek adequate management for those triggering factors, they would do well. But none of them did well if they smoked. And if we were not able to find resolution for those physical factors, then they went into the group who didn't really respond, and they just didn't do well. The third big group were patients who demonstrated huge hypnotic ability. They were inconsistent in using it, and Mike was able to find that they had a stack of gain issues or dissociative experience. They had post-trauma dissociation, and the courses of management were punctuated by paradoxical responses. They were not really sure whether they wanted to do it. They were defensive. They had motivational and other issues. And if Mike was able to help with that, then they slipped into the group of people who did very well. And if they did not, they stayed in the group that could not do well. And overall, we saw 60% long-term remission, and we saw 40% who did not. And we understood just about completely why remission was not happening. And so we're now going to talk now about the sympathetic nerves, the parasympathetic nerves, and the nervous system. Those black nerves are the ones that deal with perception, things like touch, warmth and cold, movement. The red nerves are the sympathetic nerves. These are the ones which send signals down to the somatic nerve receptors, and they change the way those receptors work so that they will give you, instead of touch, they'll give you pain. And that's, I'm making the assumption that that's why if you block those sympathetic nerves with local anesthetics, that's why sensation returns back to normal. And then we're going to say, and we're going to ask the question, well, I wonder if you can modify autonomic function using hypnosis. And I think we're going to argue later in this talk that yes, you can. The green nerves are to do with vagus, that's to do with peace and tranquility and say digestion, for example. Sympathetic nerves are to do with agitation a little bit. The sympathetic activity generally makes the heart go quicker. Parasympathetic activity lets it go slower, which is really nice. And so we got moods. Now we're going to start talking about ego states. and dissociation. And we got moods, we got peace, happiness, anger, sadness, fear and loss, contentment and more. And all of these have characteristic body languages. Got facial expressions. They got heart rates, they got blood pressure changes, skin perfusion, sweating and more. And it's all governed by automatic and autonomic function. And if we use thought, we can, generally speaking, communicate with them, and we can choose which is appropriate for the circumstances we are currently in. And each of these different moods can be termed ego states. For the most part, they communicate with our cognitive functions and they communicate with themselves. For example, if I'm peaceful, but it's snowing like it was just a couple of minutes ago here in New Hampshire, I can decide to go shovel. Actually, we didn't have enough snow to make it worthwhile that, but cognition and thinking led to change. But sometimes communication is blocked. For example, if you're angry, if severe, it's hard to choose calm because that particular ego state may be dissociated from all the others. More than that, more than physical behavior, ego states show specific autonomic patterns. For example, heart rates, skin perfusion, and so on will change when shifting from peace and rest to enthusiasm with conversation, even though the energy requirement may be exactly the same. And different moods can be termed ego states. And for the most part, they do communicate with our cognitive function. Oh, it looks like I've got the same slide in twice here. More than physical behavior. I think I got that in again too. Can ego states drive illness? We know that in CRPS, autonomic nerves alter somatic perception, changing touch to pain, causing vasospasm and muscle spasm. And blocking these nerves with local anesthetics relieves such symptoms and signs, confirming involvement. Now the question is, can hypnosis help a patient moderate these changes? The answer is yes. Autonomic nerves drive some illnesses, CRPS being one of them. Hypnotizable patients can use their skills to moderate pain, muscle spasm, and vascular changes, and then to investigate reasons why changes are needed and can be initiated, which is great. And the outcome with hypnosis looks very similar to nerve blocks. Vascular changes include skin perfusion, confirming the ability to moderate autonomic function using hypnosis. So if there's an element of control, why is this not in consistent use? What can interfere with communication? And one of the items that I like to talk about is art. And the reason is that dissociation is normal. Dissociation is normal and it's a creative function and it's fabulous. I mean, if you see a picture like this, for example, well, this applies to me. If I see a picture like this, it takes me away. And I dissociate to a degree from what's happening in my life at the current time. And I think that is great. But it's not always art that lets us dissociate. I am the host. I'm going to admit somebody. How about that? So, adverse childhood experiences can let you dissociate too. And if when you were growing up, you experienced a whole stack of dissociative experiences, traumatic experiences, there's a good chance that you protected yourself from them by dissociation. If you look at this list, you can look at various things which commonly cause children and young adults to get upset and lead to dissociation. And these are all very these are very powerful. Now, if you'd like to get these forms, I'll be sending them to Tish in the next day or so, and she's going to be able to share them with everybody who comes here. And again, each ego state has a physiological signature. A physiological signature may promote CRPS. Ego states can isolate by dissociation to protect against trauma and its memories. Ego states driving CRPS are likely to be dissociated and not fluently accessible for modification. Breaking down the barriers is needed. How can we do that? Well, a lot of it is to do with motivation. And that has to come from our wonderful clients, our wonderful patients. We have to offer sincere and gentle and creative encouragement and support. We have to discover internal potential and skills. We have to use ego state and other forms of therapy. And when success occurs, we have to reinforce it. And that's absolutely important, because the more we reinforce it, if somebody does something successful, which is part of the psychological behavior, the more likely they are to be able to persist with it. Now, I read an article from PubMed on what ego state therapy is, and I did a significant part of editing this because I wanted to abbreviate it a bit. And they define it as a psychodynamic approach in which various ego states constituting a family of self within an individual can learn to talk to each other, find out what each other is all about, and come to terms of living together again. Dissociated ego states don't normally open, except in true multiple personality. They are made accessible using hypnosis, allowing for contact and communication with their ego state family, themselves, and the therapist. Any cognitive, analytic, humanistic, or hypnotic technique may be employed to enhance internal diplomacy. Complex psychodynamic problems can often be resolved in a relatively short time in comparison with more traditional analytic therapies when we use ego state therapy. And again, any behavioral, cognitive, analytic, humanistic, or hypnotic approach may be used. We can find an image that represents the illness. We can use it on which to base management. We can use placebos. When you think about it, placebo responses are entirely do-it-yourself. They are wanting do-it-yourself responses. We can apply faiths, religious stuff, spirituality, and the reason is because many religions have routines, rituals, as it were, which help people use trance. That has to be encouraged. And whenever something gets done well, effectively, you get a favorable response, you must reinforce it. And please note that any forms of negativity will get in the way of progress, may even block it. Research and acknowledgement of findings should be questioned. My research, for example, should be questioned. I don't want you to accept what I'm saying at face value. Oh, yes, I do. But no, scientifically, yes, you should question it all. You should consider whether we can apply it to other ailments. And we have examples from our own clinic that suggest that other illnesses, but not all by any means, should be studied in this way. We should publish the findings widely, and not just in the psychological or the hypnotic literature. This needs to go into standard medicine. One of the things Jean was talking about last night when we did a trial run was that she had an empty abyss where there was no knowledge. And standard medicine has an empty abyss that there is no knowledge either. We need to publish and we need to share as much as we possibly can. Where to go? I think getting skilled in therapy for dissociative disorders is really important. Now, I don't know where to go for that, but I know it's available. It's worth checking with the ISSTD, that's the International Society for the Study of Trauma and Dissociation, because they have educational stuff. And not only that, but they have a list of people who are trained in this, which could be in your area, which would be great. Then we should continue the research and we should share the information as widely as we can. And thanks for your attention. And now it's time for discussion. Hooray! I'm going to see if I can unshare. Okay. Stop share. There we go. Oh, there you all are. Hello.
Thank you.
Hello.
Thank you very much.
I'm going to see if I can go to gallery view. If I can. Oh, there we are. Hello, gallery.
Hello. Top of the morning.
Well, I hope that was useful. I hope it's not the end of education or research. So I say carry on. Questions? And not just from the audience in the house, but questions. Do you have a system in place for people on Zoom to ask?
Yes.
They can.
Yeah. Now it's important because my expertise is looking at the whole picture. There's all kinds of things I just don't know. There are probably skilled psychologists in this group. They can present answers to stuff that I just don't know. And there are probably hypnotists in this group who know how all this will fit into the picture that we've defined just now. And I want to know more about that as well. So let's have as many questions as we can think of. Unless you'd rather not ask questions, of course. In which case I can have some more coffee. Look, this is my grandpa mug.
David, it's Tish. We spoke last night about your practice and how hypnosis actually enhanced what you do, what you did. You're retired now. I read an article, which you encouraged all of us to do, about the old name of the CRP. I forget the name. Yeah.
Yeah.
What was the old name of that?
It was called RSD, which stands for reflex sympathetic dystrophy. The sympathetic component was clear, and that would indicate that it involves the sympathetic nervous system, which it does. Dystrophy would indicate that there's a lot of atrophy of the tissues involved, which there is. Reflex, I'm not quite sure what that means. And I think that's another term that probably means that it's not terrifically well understood.
In the article, it stated that it was known commonly as the suicide disease.
Oh, goodness, yes. And that's really sad. And it's because if you have severe pain and severe loss of function in terms of not really being able to walk about or move or function, it is so depressing. And yes, it was an illness that many people sought help just simply by committing suicide, which is really, really sad. And I think we had two of the patients we were managing did commit suicide as part of what was going on. Now, these were entirely in that fourth group of people who were not responsive to hypnosis.
Good to know.
Yeah.
So David, this is Jean. And
hello, Jean.
yeah. So yeah, maybe the gain down a little bit. Thanks. So I'm really, and we talked about a little bit yesterday as well, but I've been thinking about it more, which is, what can we as hypnotists do? And obviously more training, particularly in, if we have interest in this type of work, ego state therapy type work, which frankly, as a side note, I think everybody who's been a hypnotist for any amount of time knows that you have no idea when someone comes to you because they bite their nails, You know, it could be because they were locked in a closet and beaten for most of their childhood. So you have
Yeah.
no idea. There's no way to know. You think it's some mild little thing. Doesn't sound like they need to go to a quote unquote real counselor, because we are not counselors, most of us, some of us are. But I'm not a counselor. I'm not a therapist. So the thing is, these things do come up kind of, and not only that, even not as hypnotists, there are people who freak out and trigger into their PTSD. And so two things I was thinking of, having kind of an emotional first aid kit, which we can talk about that another time. But this, like, training is one thing we can do, get some training, but what can we do to help change this bigger picture? Because here we are with tools, and there is a mental health care crisis in this country. The town I live in, the county I live in, people can't get mental health care because, you know, a psychiatrist comes into town, is there for a year, and then they move away. And then there is no psychiatrist, right? So what can we do? Because we're all, I think all of us are here because we want to help people, right?
Yeah, I am sure that is correct.
So that's what can we do as hypnotists? Like, I don't have the same voice that you have. You're an MD, right? You've got that MD behind your name. So you have a different, besides being British, right? You've got this credibility. And we don't have the same type of credibility with the medical, mental health community. So I guess I'd like you to just address that maybe.
This is one of the most important questions we talked about last night. And by that, I mean, there's an abyss which has not nearly enough information about how to manage this kind of stuff. I had extra training because I was working in the same room as a psychologist who was extremely versatile, extremely versed in this kind of work. And that was so educational for me, which is great. I think the most important thing is to be aware that having problems like these are possible. Using something like the ACE score is a good starting point because it gives us clues that we might have extra issues like this. And talking to people about the chance that they might have received trauma as adults or especially as children, that is important too. And I cannot be more specific about this because the answer to this very important question, I'm afraid I don't really know. But what I would like to see is better training, better integration with hypnosis, psychology, and medical services for the treatment of these kinds of illnesses. And there are many other ailments than CRPS, which might be something that should be looked at. Fibromyalgia is one. Chronic fatigue is another. There are others, but I don't have information on these. We saw them, but we didn't study them enough to give specific information on outcome. But if I was still working, I would be doing that. So I'm sorry, Jean, I did not answer your question, but I answered it as best I could. Scott has a question.
Well, I might just respond to Jean's question. And I think as hypnotherapists versus psychologists or medical professions, it is kind of our job to go out and meet people that have those qualifications, doctors, psychologists, counselors, and associate with them, inquire about them, because I generally find that as you do, we become a resource for them, because they're generally sending us all the patients that their particular therapeutic process does not work with, and they're looking for a solution. And so if we can offer that psychosomatic, therapeutic response that hypnosis can provide, then, I find that we do get a lot more referrals that way. So we do become that conduit to help people heal. Yeah. So, yeah.
That makes sense.
My other little question in there too is how linked is this with fibromyalgia? Because it seems like it's quite similar in terms of symptoms and
My initial impression, based on helping many people with this, is it's interchangeable. But again, I don't know I can jump up and down with glee about CRPS because I feel like I really understand it. The numbers we have convince me. If I was doing it again, I would want to do extra things like have a more specific control group other than patients who've been in therapy in other forms but not responded. There's a number of extra things that I would like to build in. But the thing about CRPS is we saw enough clients to really get what we consider to be a reasonable understanding.
Was there a greater percentage of those that responded well, where that was actually more of a psychological cause and effect versus a physiological?
And that's on that algorithm, you saw 3 pretty clear groups. The people who responded easily without interventions from big time psychology or big time surgery, they were I don't have solid numbers, but my memory says about a third of them. Again, if we were going to be doing another study, I would want to follow that more clearly.
Yeah. In that, then, is there a correlation with those that didn't respond with secondary gain of holding on to that in some way, shape, or form?
I don't know the answer to that. Sorry.
That's right. Looks like Joy raised her hand.
Yes, thank you.
Mhm.
So I wanted to join your clinic like right away. It's so powerful, all the various details that everybody has brought up. I think one of the things that in general maybe could be studied is multiple therapeutic clinics. Because sometimes I do feel, just looking at my own self-care, that sometimes physical impingements like craniosacral therapy or neural manipulation, besides the hypnotic components, I'd like to see that kind of study where the craniosacral, the neural work, Upledger, Jean Barral in France, these are trainings that I have been adding to my practice because I think it's not always going to be found in a trance state, if that makes sense. And I don't know
It
if you
does.
have any studies there, but thank you so much for your work.
Joy is 100% correct. No, 1000% correct. Yes, Joy, that's exactly right.
Looks like Michelle has her hand up as well.
First, I love the expression enhance internal diplomacy. Because when I first came into the field, the term was parts therapy. Now it's ego state therapy, and I've heard internal family systems. And I love that idea of diplomacy and just having those conversations without those right, wrong dynamics. So thanks so much for that phrase. And then I am curious about the 50% of people who benefited and saw the long-term remission and decided not to continue with the hypnotic interventions. I am so baffled by that. And I'm just wondering what your ideas or experiences is about that, about why people would benefit so greatly and not continue.
Well, I do have a very strong opinion on this, and that what I'm believing is that if you have an ego state which has the physiological signature that's actually doing you harm, it is serving a function. And if you use hypnosis and you take that function away, I think it can be very threatening. Now, Mike and I never really explored this at large. My memory is that that's what we believed at the time. And I think what was happening was that if you want people to drop an ego state, you have to discover why it is there. And once you know it, once you can help them discover why it is there, then you can help them drop it. Do you think that might answer the question?
Mm-hmm. I don't know. I never thought of parts therapy as not finding out the purpose of the part that's problematic. I always was taught that you find that positive intention for that part and what it's trying to do for you. And I hadn't really heard the grow up language in all those trainings, but find ways to have that positive intention from that part met and having that function fulfilled so that the part could redirect its energy or have that function served by another, or maybe a brand new part. So I don't know.
My view is having a high dissociative capacity is normal. It indicates a huge degree of creativity. To have an ego state which has dissociated is actually very good because it's protective. And if you want that ego state to come back, then you have to find a really sensible way for it to come back. And that's where studying dissociative ego states and what they might be doing and how to get them to talk to each other and to you and to the psychologist at the same time is vital, and it's really, really important. And again, you have to realize that my knowledge in this field is not as strong as it is about airway management or needle sticks. But it's a good start. And it's, you know, I don't mind asking questions. And if I'm not 100% sure what I'm talking about, I can ask a question too. And that's exactly what you are doing, which is great. But anyway, my opinion is what I just stated.
The part about the dissociative being creative, that's super helpful. Thank you.
Super helpful, yeah. That's how you become a musician or an artist or something of that sort.
And that's soul retrieval, right, Larry? Yeah, so from a different, pre-doctor or different medical perspective, that would
Yeah.
absolutely fit with a soul retrieval type of approach. Which,
I know a podiatrist who retrieves souls as well.
yes.
And he
You
does
see how I set
healing.
you up for that?
Yeah,
That's great.
yes, you did. Thank you.
Thank you, Dr. David. I'm curious, we put so much emphasis on the neurology of the brain. And I think I have a hunch, it could be wrong, that, and so I'm wondering what you think about the notion that the autonomic nervous system also has memory to it. And that memory can be stored outbound somatically in the body, and only when the salience of something close to the trauma gets experienced, it's like a two-part system, and that part gets fired up and it meets something in the cortex, and bang, we're re-traumatized. And that, I'll keep it short. Do you think that autonomic memory is a possibility?
Oh, yes, absolutely. You have to think, is the autonomic nervous system in charge? Is the autonomic nervous system under control of different parts of the brain? I'm sure that repeated neural involvement is a pattern that gets habituated.
Right.
So I think it's that's memory. Where it all fits, I don't know. Maybe we will learn this over the next century or so.
Well, it's the embodied idea of the brain, right? That this
Right.
isn't the brain, the whole lot.
Yeah,
Yes.
I mean, is the autonomic nervous system a component of the nervous system as a whole, or is it working independently? There's all kinds of questions that need to be asked and answered.
I would think if you reverse that with neuropeptide communication, that would be right there.
That's my hunch, but it's why you bring it up in a group, so you get other pieces.
Exactly. I'm afraid I couldn't hear that. Can you?
He's going off, Scott was mentioning neuropeptides as the communication channel. So say, we talk about, in hypnosis, we always say, listen to your heart, listen to your lungs, listen to your liver, let's talk to your kidneys for a bit, whatever, not just joking, but we really do that, then we get stuff back from that. And so is there stuff literally that's stored outbound or local that ordinarily is below to me, below consciousness just means the motor sensory side of the nervous system.
Well.
So
my
it
view-
takes a little, you got to listen
Yeah,
closer.
I understand that. Now, my view is that nerves work repeatedly, and when they work repeatedly, they develop a pattern.
Yep.
Which makes it easier for them to do the same thing next time. And when I think about hypnosis, I think that hypnosis is stage by stage taking charge of automatic functions. So, for example, if I decide I want to take over, what's the easiest one to take charge of? I think it's breathing.
Breathing.
I bet none of us have thought about breathing over the course of the last 45 minutes.
Yeah.
But here we are. If you take a deep breath right now, you've taken over from automatic functions.
Yeah.
Which is interesting. And then muscle tone. That's one. And then letting yourself relax completely, and then building in images of visual things, auditory things, flavors or smells, things of that sort. And so my view is that, yes, these are all important, and neurological patterns are repeated and learned, they are habitual, but they are available to be taken over when you use hypnosis. Now, I'll give you one extra idea. We never helped anybody with hypnosis with CRPS who had had it more than 8 years. If you'd had it for 8 years, in our experience, you were stuck.
Yeah.
And I think what that, in my mind, that means there were habitual patterns that were really truly established, that were which were very hard to access if you had had them for many years. And I suppose that supports your idea that, well, you expressed it so well.
I work with elders with dementia, and the coping strategies are fantastically robust by end of life. This is what I found. So it can be very difficult to get them to change if they so desire. I
Oh,
don't
yes.
see that a lot. It's much more do your change work in midlife. If that's what you want to do. I'm also curious, so did you guys have effectively an interdisciplinary team that talked about your patients?
Yeah, we worked very closely in collaboration.
Nice.
Most of the time, the psychologist and I were in the same room. And we talked to the patient, we talked to each other. And it was really useful for me because I learned such a lot about what was going on.
I think that's the gold standard in my experience.
Yeah.
And I my wish is that gets more widely adopted. I'm on an interdisciplinary team where I work, and they know I'm a hypnotist, but that's not why I'm there.
Yeah, my view is shared, and the concept that we were talking about is that there's this abyss of information which needs to be shared.
Yes.
And it's all very well. I mean, we're talking about a speciality.
That's
now,
right.
if you talk about a specialty like cardiology, neurology, anesthesiology, they are well understood. Training involves routines which teaching hospitals, teaching departments understand. But this particular set of concepts is not well understood. And so it's not well known. So it's hard to share it. It's hard to get a department to say, oh yeah, this is how we should do it. Let's run a training program. Because essentially it's not well understood as a general medical topic.
Thank you.
You're welcome.
We always try to get the really good looking on our reads.
I was wondering, since I'm interested in working primarily with trauma, working with especially women, whether there's training available with the ego state therapy. So I'm not sure I'm familiar with any of that in the area. Does anyone know?
Parts, I'd say like, I did parts therapy with Roy Hunter and Bruce Eimer, who also
Okay.
did work with David. I don't know if you can hear me. Can you hear me, David?
I can't hear you enough. What I would like to do, if I may, is just take a minute, because the cat is here and the cat is demanding to be fed. The cat will start screeching if I don't get up and do it. It's only going to take a moment.
Well, maybe we should have a break. Why don't we take a break and we can answer this roundtable next? We can do some more questions. We'll do that and tie that and set editing wise with the pieces.
Yeah, we'll stop the recording here. Let's not pause it, let's stop the recording here, so we don't have that long.
Wow.
We'll take a